Well, I've been told that Dr. Nasser is already here with us. Hi, Nasser. Can you hear me?
Yes.
Hi, welcome to the session, Nasser.
Thank you. Thank you, Vikram.
Thank you very much, Nasser, to you for your time. And at such a short notice, you could make yourself available. Thank you very much. And I was just telling the audience that, I have gone through this presentation of yours, which you have shared with me. You have really taken pains to, make this presentation, really. And I'm sure the audience is also going to have their views, my views, because it's a wonderful presentation. Thank you very much, Nasser. Nasser, before I hand over the session to you, we are still 4 minutes away from the scheduled time. And doctors have already started joining us, and the number is increasing. And in the meanwhile, I'll take advantage of these 2-3 minutes and introduce you to the audience.
Okay.
So please permit me. Then I'll hand over the session to you.
Sure.
Thank you. Well, Dr. Nasser Al Asmar, who is a PhD and holds the post of Scientific Advisor and Embryology Director at Igenomix headquarters, which is in Valencia, Spain. Nasser Al Asmar received his bachelor's degree in pharmacy and a master's degree in biotechnology of human-assisted reproduction at Valencia University, Spain. He has got his PhD in biomedicine and biotechnology with the topic Importance of the chromosomal analysis of the products of conception by next generation sequencing, what we call as NGS. And not only NGS, also array CGS techniques. Both techniques he is a master in for an appropriate reproductive advice. And these felicitations were awarded to him at Valencia University, Valencia, Spain. Nasser has been very instrumental in bringing up Igenomix in last many years. He was laboratory manager at Igenomix USA in Miami, Florida, from its opening, which was in year 2012, until January 2016, when he became scientific advisor, first in the US and now for Spain and Latam. Nasser has over 10 years of clinical and research laboratory experience, first at EV Valencia Clinics, which was there in Valencia, Spain, which is there in Valencia, Spain. I'm sorry, I stand corrected. At the pre-implantation genetic diagnostic laboratory. And later on at Igenomix Valencia, Spain, at the pre-implantation genetic screening laboratory. And then at Igenomix USA in Florida. In the clinical setting, Nasser has extensive experience in the study of chromosomal abnormalities in embryos, that is PGTA, and spermatozoa using array CGS technology and FISH. He is currently developing these same studies by NGS, analyzing products of conception as well. In 2019, Nasser Al Asmar had lectures in international conferences in several countries such as Argentina, India, Nigeria, Kuwait, Japan, Hong Kong, Spain, but about all different topics in reproductive genetics. It's really wonderful and a pleasure, Nasser, to have you here with us. The session is all yours.
Thank you very much, Vikram, for your nice introduction, and thank you all also for being here today, where we are going to discuss regarding the ERA, the endometrial receptivity analysis, And this is going to be my purpose today. I will make for you a kind of small introduction in order to, to put your into the information of what we perform in order to have this test going on. And then I will explain to you our last publication regarding the ERA RCT. And at the very end of the session, I would like also to show you some special cases that I'm pretty sure it's going to be really interesting for all of you in order to, to know and probably you will identify some of these real cases with your clients as well as with your patients. So I guess that you can see my screen right now. So I'm going to start. And let's start doing or taking a look into the first step of life journey into the maternal side. It's the maternal contribution, and we do know that there are several aspects that might affect the implantation of the embryo into the endometrium. We can see here that the endometrial microbiota can have potential lead into the implantation or not, this environment that is surrounding the endometrium. Also the maternal embryonic crosstalk, this crosstalk that happens even before that the embryo implants. Also, we have the process of decidualization that is really important, as you might know. But what I'm going to talk today, as I said, is going to be about the endometrial receptivity. Because it looks like that since the several years, we were doing research and doing clinical studies about sperm, about oocytes, even we analyze the embryos, but it looks like that when we perform the transfer, we close our eyes and cross our fingers and, well, let's see if the patient gets pregnant. And this is why we in Igenomix were really focused on that kind of studies in order to know the best timing for the embryo transfer. And this is what we call the puzzle of the endometrial factor. We can analyze the endometrium in different ways. We can do it like visuals using histology, immunohistochemistry, ultrasound, Doppler, hysteroscopy. We can use other techniques like OMICS, like transcriptomics. That is the one that I'm going to be focused today because the endometrial receptivity analysis is focused on the transcriptomic signature. We can do or analyze the secretomics. I talked before about this crosstalk in between the endometrium and the embryo, and this is why we are looking into the secretomics and we are researching in the secretomics. Also, the endometrial stem cells. Actually, we have a study going on when patients with Asherman syndrome and also with refractory endometrium, that with the stem cells we already achieve patients that grows again the endometrium, even got pregnant, and we also have already a baby born at home, and then this endometrium disappears again. But at least we were able to grow that endometrium again and then to have a baby for the patient. So if any of you have this kind of patient with Asherman syndrome or refractory endometrium, I can place you in contact with the principal investigator that will be happy to follow this case. And also we can analyze the microbiota. You do know that the microbiota environment is really important right now, also the chronic endometritis, in order to have a successful implantation and later on the pregnancy. So some of these studies that are the puzzle of the endometrial factor are the studies that we used to perform, and other ones are the ones that we are performing right now. So at the age of omics, we can perform different studies like transcriptomics, proteomics, metabolomics, but I'm going to be focused, as I said before, on the transcriptomics, because this is the one that we are performing for the endometrial receptivity analysis. We published this first paper in 2011 when we found a transcriptomic signature for the human endometrial receptivity. So we can use this genomic diagnostic tool in order to know the window of implantation, the best time to perform the transfer for our patients. we published at that time the 238 genes that are up or down regulated at this point, and this is going to help us to know the best timing. So we will see, in order to see this pattern, if patient is receptive or non-receptive at certain time. We can perform this kind of test in natural cycle or HRT cycle, or hormone replacement therapy. And I always like to place as an example the HRT cycle, because what we want to do is, whenever is your patient receptive, you have to repeat exactly the same, looking for days of progesterone or hours of progesterone, dosage of progesterone, and way of administration. You have to do exactly the same and replicate it into the cycle of the transfer. And we know that it's going to be easier to replicate the HRT cycle than the natural cycle. So in an HRT cycle, you will start with 7 to 10 days of estradiol, and then you are going to make an ultrasound. With this biannual ultrasound, you will like to see a triple layer that has to be higher than 6.5 millimeters. And it's really, really important to observe that endogenous progesterone is under 1 nanogram per milliliter. Because if don't, this patient can be ovulated already, so this can mislead our final results. And this is the reason that we always say that it's really important to measure the endogenous progesterone prior to start with the exogenous progesterone. So once we have this value under 1 nanogram per milliliter, then within the next 24 hours, we are going to start with the exogenous progesterone. And we will call this certain day as a P plus 0, progesterone plus 0. And we will give progesterone until day P plus 5, progesterone plus 5, or after 120 hours of progesterone, where we will perform the endometrial biopsy. And we will perform our first biopsy in that certain day, because most of the patients are going to fit in this time as a receptive. And I will show you later the results. So we used to perform this kind of analysis with the microarray, but we moved 2 years ago to the NGS, to the next generation sequencing, analyzing this 248 genes, is 238 plus 10 genes of housekeeping for control. And then we perform a bioinformatic analysis, data analysis, because the bioinformaticians are helping us in order to have a good algorithm that is going to be more accurate in order to have the better results. And with this algorithm, we are going to perform a classification and prediction from the gene expression, if these genes are telling us that are overexpressed or underexpressed. So when we move from the microarray through the NGS, what we perform also is to retrain our ERA algorithm. And now we can tell if the patient is receptive, but also we can tell you if your patient is early or late receptive, and of course as well if it's non-receptive, pre-receptive, post-receptive, or proliferative. And this is going to be really important, and I will explain you later why. Talking about publications, we already have more than 25 internal publications, and it's also really important to let you know that we also have different publications that are external. So there's nobody in this kind of publications coming from Igenomix people. So the clinics perform their own studies, they test their patients, and they publish this kind of results. Most of them are really nice and good results. Obviously, I'm not going to go through every one of them because it will take all day long. But let me just quickly explain this job. This paper was published from a clinic coming from the British Columbia in Canada, Olive Fertility Center. And what they did is that they have patients, they perform PGTA for chromosomal analysis, they transfer a Euploid normal embryo, and patient didn't get pregnant. So then they perform the ERA and transfer according what the ERA says that the patient was receptive in that certain day. So in their results, they say that those patients that had at least one previously failed Euploid embryo, they found that 22.5% had a displaced window of implantation. And when they correct and perform the personalized embryo transfer, that means transfer when the ERA says that the patient is receptive, the implantation rate went from 54 to 73%, and the ongoing pregnancy rate went from 40 to 60%. So 20% more in implantation and ongoing pregnancy rates. Even though they said that it was not statistically significant, probably because it was a retrospective study and it was a number of patients, around 88 of patients, but with bigger numbers. We're pretty sure that this would be statistically significant because it was 20% higher rates. So they conclude in their study that there was a significant proportion of patients with a history of implantation failure of Euploid embryo that had a displaced window of implantation. So let's move to our summary in this 2020, where we already performed this ERA test in more than 90,000 patients in more than 90 countries, in more than 2,700 clinics. And when you perform the first biopsy on the day P+5, we found that almost 70% of patients were receptive. So we were doing properly. So we thought that all the patients are going to be receptive in that certain day, and most of them, 70%, they were. But the interesting data for me is that this 30% of patients that were non-receptive in that day that they were supposed to be. And this is the important data and the interesting data, because we might find the reason why those patients didn't get pregnant. I say might find because we do know that there's more things in order that the patient don't get pregnant, like there may be a problem with the uterus, a chronic endometritis, but this could be one of the answers to our problem. And for these 30% non-receptives, we have most of them, almost 90% of the patients were pre-receptive. That means that needs 1 or 2 days more of progesterone. And we found 10.5% of the patients that were post-receptive. That means that they need 1 or 2 days less of progesterone. Really important as well, as far as we move from the microarray to the NGS, and also that we retrain our algorithm, and this is why I told you before that it's really important, the new algorithm, is because nowadays, in 90% of the cases, with only one biopsy, we are able to tell if your patient is receptive or not. And if it's not, we can tell you when you should make the transfer in order that the patient is going to be receptive. So before, it used to happen in 70% of the cases. So in 30% of the cases, you will need a second biopsy. But now, is this so only happening in 10% of the patients? So let's move to the second part of the lecture, and where we are going to talk, and I'm going to presenting to you our data of the RCT, our trial, where we had this kind of population. The population were IVF patients at their first appointment undergoing blastocyst transfer. And we have 3 different arms. First one is personalized embryo transfer, as I said, to transfer when the patient is receptive. So you have to vitrify the blastocyst and then perform the ERA. And whenever the ERA say that patient is receptive, you thaw the embryos and you transfer it in HRT cycle. We have the second arm of the study that is frozen embryo transfer. So you have to vitrify the blastocyst and then transfer it in an HRT cycle. And we have the third arm of the study where you have fresh embryo transfer. So then you go through to blastocyst stage and transfer to the patient. So our primary objectives were live birth and cumulative live birth rates at 1 year follow-up. 1 year follow-up means that you perform first embryo transfer, and if the patient don't get pregnant, you make a second one or a third one, or a fourth one, up to 1 year. If patient is pregnant at the second one, you obviously stop. If the patient doesn't get pregnant and you make one transfer to another and patient don't get pregnant after 1 year follow-up, we stop as well the analysis. And as a secondary objectives, we were looking for implantation and pregnancy rates, biochemical and clinical miscarriages, ectopic pregnancy, obstetrical neonatal outcomes, and cost effectiveness as well. And this is only to show you that this study took us 5 years was the study length of the study, with 4 years of recruitment length of patients. So those are the 16 study sites all over the world, and those are some of the RCT selection criteria, either inclusion or exclusion criteria. I'm going to go really quick by the exclusion criteria. They were excluded patients with recurrent miscarriage, with severe malfactor, with implantation failure. That actually it used to be only the one, or only one of the indications to perform the ERA was implantation failure, and we exclude this criteria in our patients. We would like to make it for the patients at the first IVF appointment. So we move this implantation failure. Also, any pathology affecting the endometrial cavity must be previously operated. And we also had post-randomization exclusion criteria. And just as a note, the PGTA was not an inclusion criteria, neither an exclusion criteria. But the three groups of them, they were statistically non-significant, so similar numbers for PGTA cases, although very low. It was very low number of cases, but it was similar distributed into the three arms. So this is the flow diagram that I'm not going to go through every of it, but you can see that we started with the enrollment with 569 patients, and at the end we were able to randomize 458. You can see that those patients were allocated to the first one, the personalized embryo transfer, to the frozen embryo transfer, or the fresh embryo transfer. And we had this kind of patients in each group for intention to treat analysis. But what I'm going to explain to you in the next slides is going to talk about per protocol analysis. And I realize that intention to treat is important, but if I want to prove that a new technique or a tool it's working for any purpose, I have to follow the protocol. Obviously, if I have this tool, I'm telling you that use this protocol, but you use another one, you cannot tell me that it's not working because you are not properly following the rules to this protocol in order to be accurate, to have good results. So this is why I'm going to focus in this per protocol analysis. Let me show you the reproductive outcomes, as I said, at the first embryo transfer, and also cumulative during the first year follow-up. And you can see here that we have several data for several things that we were looking for, but I'm going to show you the ones that are more relevant for me. And again, we have these three first are related with reproductive outcomes at the first embryo transfer. And remember that those were patients at the first appointment. And then we will take a look to the cumulative pregnancy rate and cumulative live birth rate in the first year follow-up. So looking for the pregnancy rate, you can see in here we have fresh embryo transfer, 58.5% of pregnancy rate, frozen embryo transfer, 54.3%, personalized embryo transfer, 72.5%. And also, if you take a look implantation rate, we have fresh 38.6%, frozen 43.2%, and personalized embryo transfer 57.3% being statistically significant. If we move to live birth rate, and if we remember that this was at the very first embryo transfer, fresh, frozen, or personalized, we went from 45.7 in fresh embryo transfer of live birth to 42.4 in frozen, up to 56.2% in personalized embryo transfer. So this was not statistically significant, but if you take a look to the numbers, you can see clearly a trend. And you can observe that comparing fresh to personalized embryo transfer, you have 11 percentage points higher from the personalized than the fresh, and 14 percentage points higher if you compare frozen to personalized embryo transfer. So if you're telling me that I'm going to have a live birth rate higher than 10 percentage points, I will tell you that I will use this kind of tool. Then if we move to cumulative pregnancy rate, you can observe that this is for fresh 63%, 70% for frozen, I'm sorry, and 95% for personalized embryo transfer. And cumulative live birth rate, it was 49% for fresh, 55.4 for frozen, and 71.2 for personalized embryo transfer. So also we check the cost effectiveness, but only to have a baby at the first attempt. And if you compare numbers in the US and the European Union, you can see that the estimated cost of a delivery with at least one live birth at the first attempt, it was the lowest was the one doing the fresh, because obviously you don't have to vitrify, but then it's going to be better to perform the personalized embryo transfer than performing the frozen embryo transfer. And if we do cumulative, it's going to be the cheaper, it's going to be the personalized embryo transfer. So the RCT take-home messages that I will tell you in order to keep it for you, it's that by per protocol analysis, we had 14 percentage points of live birth higher from personalized embryo transfer versus frozen embryo transfer, and 11 percentage points higher versus fresh embryo transfer. And even though it was non-statistically significant, but we observed a clear trend. And we observed a statistically significant improvement in cumulative live birth rate, cumulative pregnancy rates, and implantation rates. Also important thing for this study was that we observed similar clinical outcome between fresh and frozen, and the obstetrical, delivery, and neonatal outcomes were not different between them. The limitations or the reasons of occasion of this study, it was the first one, the main limitation of our study, it was the unexpected added 20% patient drop-off rate versus the 30% initially planned. So at the end, we had almost half of the patient dropout rate, and we think that is because this kind of multi-center analysis with 16 centers involved. So at this point, we have this lack of patients that we were pretty sure that if we have only 30% dropout rate that we initially planned, for sure the live birth would be significant. So that some physicians asking me, Nasser, you should go farther, you should still put in more patients. But again, this is a study 5 years length, so we cannot be all the life doing 1 year more and 1 year more. We have to wait also to the baby to born. So we think that we have a strong tool in order to start trying to use it not only for implantation failure, but for other recommendations such as first appointment. This study was powered to detect statistical differences for a 15 percentage points increase in the primary outcome. So this is also difference. It was doing for 15% instead to be for 10%, for instance. And as I said, we think that this is the first RCT to provide proof of principle evidence for the potential of using a personalized diagnosis of the endometrial factor in the workup of the infertile couple at the first appointment. So saying that, I'm going to move to the last part that, as I said at the very beginning, I think that it's going to be interesting because you might look some of your patients in these special follow-up cases. All of them are real cases that we had in Igenomix, some of them from Dr. Carlos Simon, some of them from you, other doctors all around the world. So let's move with the first typical ERA case. It's a recurrent implantation failure patient, 39-year-old, normal routine infertility assessment, with partner karyotypes, semen analysis, including fish, biochemicals, coagulation and immunological parameters in the female. And then also hysteroscopy revealed a suscepted uterus, so they performed a surgical correction, achieved normal morphology. So this was the workup of this patient. This patient did a couple of cycles in one clinic with a routine workup that it was negative. Patient didn't get pregnant. She moved to a clinic that in that time Dr. Carlos Simon was working there. This was a patient from Dr. Carlos Simon. They performed 5 different cycles, trying the different strategies with fresh transfer on day 5, frozen on day 5, then move it into the egg donation in day 3 in HRT cycle, day 3 in natural cycle, day 5 in HRT cycle, patient didn't get pregnant. After 7 cycles, the ERA came out, so we were able to do the intervention to perform the ERA, and we found the personalized embryo transfer. We found that the window of implantation of this patient was displaced, and we performed the last cycle with ovum donation, with double embryo transfer, because at that time you told the patient that use their own eggs, and single embryo transfer, and the patient said, no way, after 7 cycles I'm gonna do that. So at the end, the good news was that the patient was had successful twin pregnancy, and they are a baby born right now with the family. So let's move to the second follow-up case. This is if the ERA can be performed on a patient with an atrophic endometrium. So this is a recurrent question that we have in our lab. If you have a patient with an atrophic or hypertrophic endometrium, can we perform the ERA? So, well, considering that under 6 millimeters is atrophic and over 12 millimeters is hypertrophic. So what we say is that we can perform it if this atrophy, hypertrophy, is consistent in all the cycles of the patient. If there's only one cycle and the endometrium doesn't grow, but typically has good thickness, then we consider that cycle should be repeated, since it would be clearly problem in that specific cycle. And this was a case that we had. First biopsy, HRT cycle on P+5, 120 hours of progesterone administration, that this is the regular that we usually perform for the first biopsy. The patient was 1 day pre-receptive with an endometrial thickness of 5 millimeters the day before the progesterone intake. And second biopsy, we did it 1 day later, HRT cycle, P+6, 144 hours progesterone administration. Patient becomes receptive. In this case, she had an endometrial thickness of 5.5 millimeters, and we had a baby born with this kind of transferring with a patient under 6 millimeters. And as you can see here, what could be the differences in between a normal thickness versus an atrophic or hypertrophic endometrium? You can observe that if you have an atrophic endometrium under 6 millimeters, we found that the receptivity is going to be lower than the non-receptive results. As you can see here, that would be the normal one. But once you find the window of implantation of the patient, you are going to have same clinical results that if the patient had an same endometrial thickness. You can see here that for hypertrophic endometrias, also the rate of the receptivity is different than the normal one. But at the end, if you find again this window of implantation, the clinical results are going to be similar. And this is a case, it's a case reported of a live birth after embryo transfer in an unresponsively thin endometrium, that you can observe that this endometrium was only 3.5 millimeters of thickness on that endometrium. And this patient got pregnant and have a live birth after this embryo transfer in a personalized window of implantation. Moving to the next follow-up case, we do know also that usually the window of implantation lives between 24 to 48 hours. But we do know that there are some patients with a narrow window of implantation that lasts less than 24 hours. So in those patients, it's really crucial to know exactly when is the window of implantation. So in this case, that was a patient from Dr. Carlos Timon. We had first biopsy with HRT cycle and P+5 with 120 hours of progesterone administration, and the patient become post-receptive. So then we performed second biopsy in HRT cycle at P+4, because this was the thing that was indicated in our algorithm, and 96 hours of progesterone administration, and the patient becomes 1 day pre-receptive. So at this point, we did the personalized embryo transfer at day progesterone plus 4.5% for day with 108 hours of progesterone, because we do know that those patients, it's in between with a narrow window of implantation, and this patient had a successful pregnancy. How about those patients with a bicornuate uterus? So what we do recommend when we have a patient with a bicornuate uterus is to perform 2 biopsies. 1 biopsy per horn, left and right, at the same time, because different results can be obtained. We might have same result for both, but different results can be obtained, and this is the case that I'm going to show you. The right horn with atrophic endometrium, we obtained 1 result. We had normal left horn by ultrasound assessment. We perform, as I said, 1 biopsy per horn in HRT cycle, 120 hours with progesterone administration. That again, this is the regular thing that we always recommend for the first biopsy, and those were the results. The right horn had pre-receptive result, the left horn was receptive. So then we do recommend to transfer in this horn because was receptive, and patient had a successful pregnancy. So according to our internal data, 89% of women with a receptive endometrial profile reach receptivity with 1 more day of progesterone administration. But 11% of patients would need more or less progesterone administration to reach receptivity. And I'm going to explain you in this real, again, example. First biopsy, perform HRT cycle, P+5, 120 hours with progesterone administration. Patient was 1 day pre-receptive. Okay, so let's give it 1 day more of progesterone. Second biopsy, HRT cycle, progesterone +6, 144 hours. Patient is still 1 day pre-receptive. So with this data, we do know that patient is a slow responder to the progesterone. So in this case, what we would recommend for the third biopsy is to perform HRT cycle, not at P+7, but at P+8, 192 hours with progesterone, because we might give it to the patient and make the biopsy in P+7 and still become 1 day pre-receptive. So in this case, we would like to move and to jump from day 6 to day 8. And in this case, patient become receptive. But in the case that patient become post-receptive, we will know that the window of implantation would be in between 6 and 8, would be P+7. But in this case, third biopsy HRT cycle, patient was receptive at 192 hours with progesterone administration, and the patient got pregnant. Also, it's really important that we know that there's no correlation between cycles. I started telling that you have to be really focused in order to replicate exactly the same what you perform in the cycle for the biopsy than in the cycle for the endometrial transfer. You can see that the endometrium in most of the patients respond differently to different progesterone administration methods. In example, intramuscular, vaginal, oral, and or to a different dosage. In example, vaginal 2 milligrams per day or vaginal 800 milligrams per day. So in this case, you can see that a clinic performed first biopsy HRT cycle at P+5 with 120 hours with progesterone administration, and the patient becomes late receptive. So we do recommend to perform the personalized embryo transfer with 108 hours of progesterone. In this case, they perform intramuscular, but in the next cycle, we receive a second biopsy for this patient that we already make the diagnosis and we did the recommendation in order to perform the transfer. But looks like that they perform exactly the same HRT, P+5, 120 hours, but they did it vaginal progesterone. So as you can see, with same conditions but different administration, we found different results. Late receptive versus pre-receptive. So in this second case, we would recommend to perform personalized embryo transfer with 144 hours of progesterone. So in this case, and with the second biopsy, we place a note on the report and we claim that this ERA cycle medical protocol was different from a previous ERA medical protocol, and therefore the two results do not correlate. Each result should be assessed separately. That means that if you as a physician are going to transfer with intramuscular progesterone, you have to transfer in 108 hours after the first intake of progesterone. But if you are going to do the cycle of the transfer with vaginal progesterone, you have to perform the transfer as after 144 hours of the first intake of the progesterone. So I said also at the beginning that's really crucial and really important to measure the endogenous progesterone level the day that you are going to, or you want to start with the exogenous progesterone. And the reason is because high doses of estradiol from the beginning of the cycle should be blocked ovulation. However, it must be always checked that endogenous progesterone level should not exceed this quantity that I mentioned before, 1 nanogram per milliliter within the 24 hours prior to start exogenous progesterone intake. Because if those levels are higher, this 1 nanogram per milliliter, the cycle should be cancelled and start over in a subsequent cycle, as an early exposure to progesterone can alter the results, affecting the accuracy and reproducibility of the results. And this is the same that I said at the very beginning of the presentation, where we were comparing this HRT cycle. And this is the real case that I'm going to show you, where we have patient, as always, HRT cycle, P+5, 120 hours, becomes post-receptive. The endogenous progesterone, because this is a data that we always ask to you, we observed at the test regression form that endogenous progesterone was at day P+0, 5.5 nanogram per milliliter. That means that exceed this 1 nanogram per milliliter. So they perform second biopsy, same conditions, and this time becomes receptive. Why? Because endogenous progesterone before the P+0 was under or below 1 nanogram per milliliter. In this case, 0.8 nanogram per milliliter. So this is why we need to measure the endogenous progesterone prior to the first intake of exogenous progesterone. And also there's a recurrent question that talking about uterine surgical intervention prior to the transfer. When should we perform the ERA test? Well, we always say the same, that it is imperative that the endometrium be in the same conditions during the transfer as it was during the ERA mock cycle. If any surgical interventions are necessary, then should be performed before the ERA mock cycle, as this could affect the answer of the endometrium if performed in between cycles. So always you perform the surgery before, and then you perform the ERA mock cycle for the endometrial biopsy, and then you perform the transfer. And this is what we found. We had a case, a real case, with a biopsy in HRT, P+5, 120 hours. Patient was post-receptive, and the patient had a myomectomy performed between the two cycles. So we did recommend to perform a new ERA in order to see if there is any change, and we found it. We found that at this time in HRT cycle, P+5 and 120 hours, the patient was receptive. So just to conclude, I would like to tell you that the best day for the embryo transfer from the uterine perspective depends on each patient. The transcriptomic signature, the ERA test, reveals that the endometrial factor is responsible for close to 30% of the cases of patients with recurrent implantation failure. The personalized embryo transfer normalizes the clinical results. As I said before, when you find the window of implantation of the patient, you are going to normalize the clinical result of your patient. And the multicentric RCT is the first study to provide proof of principle evidence for the potential using of a personalized diagnosis of the endometrial factor in the workup of the infertile couple of the first appointment. And just let me tell you a comment with this table that we do know that we have competitors talking about the endometrial receptivity, and I don't want to talk about anyone. I only talk about what we do. The only thing is that I show you the data, and you can take your own conclusions. You can see how many genes we have to analyze, what is the technique that we use, what are the published papers talking about the development of the technique, and also with the clinical validation. So this is the thing that I wanted to show you. And just to finish, to show you our view, we know from the very beginning of the IVF, from the 1978 up to 2010, we had better results. We were improving up to the 30% of live birth rates, starting with the chromosomal analysis for all 24 chromosomes with the RCGH, SNP array, qPCR. We were able to add 15% more, transferring these normal Euploid embryos. And we do think that with the help of the endometrial factor, is around more than 10–15% of the endometrial factor, is going to help us to have a better rates in our clinics. That we know that in medicine, in biology, it doesn't exist 100%, but we need to be close of it, of course. So that's all. I would like to thank our colleagues in Igenomix, Professor Dr. Carlos Simon, as one of my mentors, and of course all the team that is working right now probably in order to let me to be here today with all of you. So thank you very much for your attention, and if you have any question, I would like to try to answer to all of you. Thank you very much.
Thank you very much, Dr. Nasser, for this wonderful presentation. And I should really admire and appreciate your effort by incorporating these follow-up cases. I'm sure the audience must have enjoyed and taken some message out of these follow-up cases, because these cases can come up with any clinician in any given clinic. It was wonderful. It was different than routine. Thank you very much, Nasser, once again.
You're very welcome.
Thank you. And let me not forget to thank the audience for being here with us in the middle of the week at 5 o'clock, you know, when they are usually busy. This is a stamp. This is a stamp on the fact that the doctors are really keen. They were really keen to know more about ERA, endometrial receptivity analysis. Thank you very much, all the doctors in the audience there, for being so patient and sparing your time for today's web-based session on endometrial receptivity analysis. Before I begin, I have some questions which are pending, rather. One question is from Dr. Rajeshri. She is asking, is it necessary to start estradiol at 6 milligram per day, or we can start 4 milligram also, like this?
Yeah, you can start with 4 milligram also. The thing is that we have a protocol that we can share with all the physicians that they want. That is the protocol that uses Dr. Carlos Simon. But the reality is that you can use whatever protocol you are using in your clinic. The only thing and the important thing again is that this protocol that you are using, even 4 or 6, if you're using for the cycle of the MOX cycle or for the biopsy, if patient becomes receptive that certain day, use exactly the same for the cycle of the transfer. So this is the really important thing. So it doesn't matter if you follow one protocol or the other one. The important thing is that one protocol is used for the MOX cycle. You replicate exactly the same in order to days or hours of progesterone, way of administration, and important always the dosage exactly the same. Usually the part of the estradiol, it might change a little bit, but the most critical part is going to be the part of the progesterone after the first intake of progesterone, after to measure the progesterone, the endogenous progesterone the day P+0.
Thanks, Nasser, for taking up this question, and I'm sure it must have addressed Dr. Rashi's query. This is another question from Dr. Dipankar. The question says that how to do ERA in those patients who have irregular cycles, like patients of polycystic ovarian disease. What is day 2 for them? Should we induce their cycle with progesterone? And if so, which progestogen?
Okay, so we this was a question that we got before in another webinar, that we didn't find anything related with patients with PCOS and the ERA. So what we recommend is whatever they are inducing or whatever they are using at the clinic in order to try to make these patients to have a good thickness of endometrium is the way that to perform it. So to do the endometrial analysis, it's going to take later on. So none studies related with PCOS so far. And again, whatever they are using in their clinics in order to grow the endometrium for these kind of patients with irregular cycles and so on is what they have to use. As I mentioned, for the endometrial thickness, if we have patient that has regular cycles and one cycle, when you want to do the mock cycle, is below this 6 millimeters of thickness, we do recommend to cancel the cycle and to do it again in the next month. But if you have a patient that it's always with an atrophic endometrium or hypertrophic endometrium, then you go ahead, you perform the mock cycle, and then you perform the transfer in order to see if the window of implantation, when the mock cycle tells you that the patient is it's receptive. But yeah, they have to use whatever they are using for these kind of patients with irregular cycles, and very much we didn't find any relation with patients with PCOS and patients with an ERA performed.
Thank you again, Nasser. Nasser, this is a question from Dr. Priya Selvaraj. She writes that she first of all appreciates this presentation. Thank you very much, Dr. Priya. Now she has a question. Has serum progesterone been measured on day of ERA testing to assess what optimal value of progesterone in the luteal phase correlates best with the receptive endometrium in ERA report? This is our first question.
Okay, I guess that the mean is that if we measure the progesterone the day of the transfer, in order to see if it's going to be better to have this kind of quantity of level of progesterone or not. And if this is the question, we don't measure that part, even though there's different works that say if there's higher than 1.5, don't transfer. Another talks about 1.2, that you should cancel the transfer. But for the ERA, we didn't see any correlation with this. And with the ERA, we are looking for the timing and for the response of the patient to this progesterone, exogenous progesterone. So this is why we are having a window of implantation in that certain point. And the measurement of the level of progesterone is something that is a part of the finding or the looking for the window of implantation of the real spot for this patient in order to be transferred.
Actually, Nasser, I will stay on this question a bit more. I think what Dr. Priya is asking us, whether the serum progesterone is to be measured on the day of ERA testing. If I have perceived it rightly, Dr. Priya, serum progesterone is to be measured 24 hours prior to starting the exogenous progesterone, number one. And number two, her question is, that as per our recommendation, the endogenous progesterone level should be less than 1 nanogram per ml. However, Dr. Priya, in her day-to-day clinical practice, has observed that she has had pregnancies even when era cycle was normal, and transfer cycle showed 3 nanogram per ml, and patient insisted on transfer based on her endometrial receptivity thickness alone. So have you correlated what was the thickness on an average when the era came as receptive?
We do check this endometrial thickness in order to see how many patients are going to be receptive or not. But again, as I saw in those cases, in those follow-up cases and special cases, you saw that that I show this live birth after endometrium with only 3.5 millimeter thickness. And also talking about the progesterone, we always claim that over 1 nanogram per milliliter can mislead into our recommendation. But this, and I'll show you also a special case when you perform with 5.5, we obtain one result, but we perform under 1, we obtain another one. But we do recommend to have less than 1 because it might mislead into a different result, but could be that you have the window of implantation, and I said it should last between 24 and 48 hours. So this can move a little bit only. So it's not gonna impair the possibility of get pregnant at that point. But imagine that there's a patient with narrow window of implantation. We could be out of this limit because the exogenous progesterone endogenous progesterone prior to first intake of progesterone that certain day, it's going to mislead into the final result. So yes, you can have a patient pregnant even though they wanted and they have a different amount of nanogram per milliliter that certain day, but this is our recommendation because we observe it and we prove it in those special cases that this could lead into a different result at the end and a different recommendation that we want to perform to the clinic. And the thing is that we would like to be the more accurate as possible because we know that sometimes patients are with the last embryo, kind of last opportunity. So this is why we try to be as much accurate as possible in order to have the higher chances that those patients get pregnant at the first transfer if possible.
Nasser, our recommendation is that in HRT cycle, we have to replicate the cycle, the transfer cycle also, the same as we did in the era cycle, completely replication. So is it important that in the transfer cycle also we should measure the serum progesterone, endogenous serum progesterone? Is it important or it's not required in the transfer cycle?
It is important to replicate. So whatever we perform in the first cycle, we have to do it in the second one. And actually, what if we perform something before, like we have to give the patient antibiotics or any drug because any reason, I always recommend to check with us, to send an email to our medical department of the ERA, because we already proved that some medicines, some drugs, it's not, even you give it to the MOX cycle, it's not necessary to give it into the cycle of the transfer. But there are certain drugs that we don't know still if it can have something to do with the endometrial response or not. So then we might recommend to replicate exactly the same. But for this kind of cases that you have a drug with, I don't know, antibiotic or anything that we provide the patient prior to do the ERA, we always recommend to check with us and we will let you know, because again, we say that we perform the ERA in more than 90,000 patients. So we have a lot of number of different drugs, different cycles, different kind of things. So we will let you know what is the best approach in order to have the most accurate results.
Thank you very much, Nasser. Nasser, this question again comes from Dr. Priya. How many cycles should pass between the hysteroscopic surgery and performing an error test? What should be the gap between a hysteroscopic surgery and performing an error?
If the patient is okay, it can be done at the next cycle. Okay. So it's important that, again, we perform first the hysteroscopy and then we perform the ERA and not the opposite way. But if patient is okay, we can perform it in the next cycle.
Perfect. Thank you very much. This is a question from Dr. Preeti. It says, what if the error report says that the results are non-receptive?
Yeah, well, usually with a non-receptive, we are going to recommend either transfer the day that we observe that the patient is going to be receptive, or in 10% of the cases, we will recommend to make a second biopsy in order to find the window of implantation of this patient. So the non-receptive actually, for me, is the good result, because if your patient is receptive, it's perfect. So you know that you can go ahead with the embryo transfer. But if it's non-receptive, this is when you might find the problem with the patient. You might have the answer why this patient didn't get pregnant before. So then we will recommend, or in this first biopsy, non-receptive, but you can make the transfer this certain day, or we do recommend to make a second biopsy in this timing in order to be sure that the patient is going to be receptive in that certain point.
Thanks, Nasser. And this is a question from Dr. Hima. She has appreciated the presentation. And her query is regarding diagnostic hysteroscopy. The question is, does doing a diagnostic hysteroscopy at the same time as error sample affect the error report by any chance?
Yeah, we always recommend to do it separately in order not to have, because we don't have enough data in order to know if this might mislead in certain way or to damage the result of the ERA. So this is why we do not recommend it to do it together. So if you have to do an hysteroscopy in order to check everything, but in the case that you have to perform it, we also say that take the sample before you are gonna put anything in there in the uterus and do it the expansion of everything. But again, what we do recommend is to, if it's possible, do it in another session.
Okay. Thank you, Nasser. Again, a question from Dr. Priya. Should we have the same thickness of endometrium between the error cycle and the transfer cycle in receptive cases?
No, it's not necessary. So usually the good thing is that you have an endometrium that is higher than 6 or 6.5 millimeters, but the patient can be 7 in one cycle, can be 8 or 6 in another one, and it doesn't matter regarding the result that we got with the ERA. So should be, could be, but it's not mandatory. Again, as far as the patient is receptive, it's okay. Other thing is that if you have a patient that has higher than 6.5 millimeter, you do the mock cycle and patient is receptive, for instance, in P+6. Then you perform another cycle and the patient don't respond very good and has an endometrial thickness of 5 millimeters or 4.5. So then we do recommend to cancel this cycle, because we already know that this patient in other cycle had a normal thickness. So we do recommend to cancel this cycle and do it again in order to achieve higher than 6 or 6.5 millimeters of thickness.
Nasser, thank you. Nasser, before this question, there was a question from Dr. Hima, if you remember, asking whether diagnostic hysteroscopy will have any impact on the ERA sample and the ERA report, wherein you suggested that if it is done separately, that is better. Related to this question only, she has asked that do we suggest doing ERA and diagnostic hysteroscopy in different months?
So you do it in different months. That means that you do hysteroscopy in 1 month and the ERA in the other month?
Yeah, is that what you meant by your answer, or she's asking whether we can do it since you said that better is to do it separately. So now she's asking whether you are suggesting that hysteroscopy and ERA sample should be done in different months. Is that what you meant?
Yes.
Okay. 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 Thank you very much. There is one more question from Dr. Priya. Have you seen better results with vaginal progesterone, or is there no difference in modes of administration?
Okay, this is something that we try to check if we had better results with one progesterone or the other one. We couldn't relate it, but there is different clinics that claims that using one or the other one, it works better for them. But the realistic thing is that for us, as laboratory, that we have patients for all over the world, and we have different kind of progesterone administration in different ways. We didn't see that one progesterone is going to work better than the other one, because if this would be the case, we would recommend to use this progesterone, and we would say, okay, use this one because we observed that it works better than this other one, but we didn't see this approach. So this is why we do recommend to use whatever you are using in your clinic and it's working in your clinic, and then just to replicate it into the transfer cycle. So no, we didn't observe this kind of one is better than the other one or the opposite.
So Nasser, you mean that whether it's progesterone is given vaginally or it's given intramuscularly, it depends on the experience of the clinic, right?
Absolutely, and it's also different between different patients. So in different patients, it's working in a different way. So this is why we recommend, if the clinic is using one of the progesterone administration, and sometimes we observe that a patient is proliferative, for instance, and the second cycle is still the same. So we, in Igenomix, we check what is going on, what is the administration, what is the dosage, and only a few percentage of patients, but in this few percentage of patients, we might recommend to change the way of administration or the way or the dosage of the progesterone in order to see if this patient is going to be a better responder to one way to the other way. But in general, we didn't observe that this one is better to the other one.
Thanks again, Nasser. Nasser, one more question is there from Dr. Shrija Karan. She's asking that, as you discussed during your presentation, that we can do ERA in a woman who has hyperplastic endometrium. How to time it in such women? How to time ERA in such women?
How to do the timing?
Yeah.
It's exactly the same. So the timing are going to be the same in any kind of endometrium, even an atrophic or hypertrophic endometrium. The normal one is going to be the same. The only thing is that with these patients with hypertrophic endometrium, we should expect that the percentage of receptive patient is going to be lower than those patients that have a normal endometrial thickness. But this is the only thing. All the timing, all the protocol has to be the same for patients with atrophic, with normal, or with hypertrophic endometrium.
Thanks again. Dr. Minu is asking, after how many implantation failures do you recommend to go for ERA?
We used to recommend it after 2 implantation failures. It was the principal indication. Patient with implantation failure is after 2 implantation failures after transferring. But also there was an indication, for instance, patients with egg donor program, you transfer an embryo coming from an egg donor and patient don't get pregnant, so you might recommend to perform an ERA. Also, you perform PGTA and you transfer a nice, beautiful Euploid embryo and patient don't get pregnant, you might use the ERA. But also with this last randomized controlled trial that I show you, it might be benefit for a patient that goes to first appointment to know if the window of implantation is misplaced or not, because at the very beginning you are going to focus on the endometrial part and you will know if patient is receptive or not. If it's receptive, okay, this is okay, let's move on the other things. But if it's non-receptive, you already know that you have something that could happen because this kind of damage or because you have a window of implantation misplaced. So implantation failure, 2 or more failures, but you can do it as well for all the rest of the indications that I said. Even our RCT recommends that you might use it in case that you suspect something about endometrial factor. You recommend to do it at the first appointment.
Thank you, Nasser. Nasser, few more questions. This is a question from Dr. Pooja. She's asking, is ERA recommended in recurrent miscarriages also, or only in implantation failures?
Okay, for recurrent miscarriages, we don't have any study with recurrent miscarriage. We have something related with a topic or biochemical miscarriages that looks like that those patients that are close by the window of implantation, like early or late receptive, might have more biochemical miscarriages. But for recurrent miscarriage, I think that we should focus more on, for instance, parental karyotypes, or to check for PGTA for the chromosomal abnormalities, because we know that more than 50% of the miscarriages in the first trimester are due to chromosomal abnormalities. Even more, it's higher than 60% when a patient goes through assisted reproductive technologies. It's higher than 60% the chromosomal abnormalities in the process of conception of a first trimester miscarriage. So for this kind of patient of recurrent miscarriage, I will look more for the part of the embryo than for the part of the endometrium.
Nasser, you remember this diagnostic hysteroscopy and ERA sample question. Dr. Priya has a comment here. She has a comment to make. She says, in premature ovarian failure patients, we have performed diagnostic hysteroscopy along with ERA, taking care to take the ERA biopsy first in the undisturbed endometrium. And later on, maybe on the same day, perform hysteroscopy. You have any comment to make here?
Sure. This is something that I commented also the first time that you asked it to me. That my concern is that I always like to do the different techniques on different timings. But if we have to do on the same day, we should do it prior the ERA, prior to do any expansion of the cavity or anything. This is what I said at my very first answer. But I like to do always separately, but it's okay, doctor. The doctor, it's right. If they want to do it the same day, they should do it in this way that she said. It's to do it first prior to do any intervention, any expansion, and then you can perform even the same day the second thing. But yeah, I'm kind of like to have everything in separately in order just to try that nothing affected to the transcriptomic. But yeah, she's right.
Again, Dr. Priya has a comment to make. This is pertaining to the question of Dr. Pooja. Is ERA recommended in recurrent miscarriages or also or only in implantation failures? You have beautifully replied it, but you must not be aware, I think, Nasser, that in India we have a combo pack of ERA plus PGS. So Dr. Priya says that ERA plus PGS can be implemented in cases of recurrent miscarriages.
Absolutely. Absolutely, because you are looking for the whole pack. I mean, I said always that here in Spain that more sugar is going to be sweeter. So if you're analyzing the part of the embryo that it will take like 75% of the chances to have a miscarriage, and then you have this second part that it will take like 25-30% of the probabilities that the patient gets pregnant, for sure this kind of pack with the PGTA plus the ERA can be applied to a recurrent miscarriage patients, of course.
Thank you very much, Nasser, for taking up all these questions. And, you know, I'm sure the replies have gone through to all the concerned doctors who raised their queries. And there is one more question from Dr. Pooja only, who asked whether it's for miscarriages or implantation failure only. She is asking, does receptivity changes before and after cesarean section?
Could you repeat, Vikram, please?
Does the endometrial receptivity change before and after the cesarean section? You know.
Yeah, I don't think it's going to change. But what we always recommend is that check with us, because we are having more data and data. We perform some studies with donors doing the ERA 1 year and then doing the ERA 3 years apart, and it's exactly the same. If there's any intervention, we always recommend to make this comment directly as a question to our medical team again, or Vikram. They might ask to you, and we can follow up from here from the HQ in order to check this patient if we should recommend to do a new ERA, because it might change or not. I don't think that C-section should change the transcriptomic of the patient, but again, I would recommend to the doctor to ask in case that they have the patient in this situation, in order that we check all our data and we can give a proper answer to this certain question.
Thanks. Nasser, I'm sorry, there is one more question. This is from Dr. Priyanka Mohan. She's asking again about diagnostic hysteroscopy. Does the endometrial receptivity change if we do hysteroscopy in between the ERA and the transfer cycle?
Okay, the thing is that we at the very beginning think that it might change, but with the several analyses, what our medical team observed that it's not changing. This is why when you ask me if I do the hysteroscopy, I would prefer to do it like in different timing, but it's true that in our team, we check our previous results. So we now recommend, if you want to do it the same day, you do first the ERA, you do after later on the hysteroscopy, and it's not going to change. This is why we are recommending in this timing, because if don't, we cannot make this comment or recommendation, because it's going to change. It's not going to work. So at that point, our recommendation would be, if you are going to do it at the same time, again, do it first the ERA, then the hysteroscopy, and it's should not change anything related with the result of the ERA.
Thank you, Nasser. Nasser, this is Dr. Dipankar, though you have replied to the question earlier, but I think he was not present at that time in the audience. His question is, in PCOD cases, you remember there was a question in frozen embryo transfer in later cycle. I want to do ERA. How to decide day 2? Because he's talking about, yeah.
I was telling, if I remember that question, that you can perform. We didn't find any relation, or we didn't perform any study in patients with PCOS and if it's something related with the ERA or with the window of implantation, if it's moved or not. So what we do recommend is that treat that patient the regular way that they usually treat those patients on the clinic, and then just follow the protocol for the mock cycle that you have to replicate into the protocol of the transfer. But again, we didn't find any relation, and we didn't perform any study with this kind of patients with PCOS and ERA. So just treat the regular way that they treat the patients at the clinic.
Okay. There is Dr. Deshmukh, who wants to know about the various interpretations of ERA sample in short, like receptive, non-receptive. Perhaps this is what the question means.
So about the interpretation?
Yeah.
So what I explained a little bit earlier that we use an algorithm, and we train this algorithm in order to see if we said patient is pregnant when it's receptive or late or early receptive, and we feed up this internal algorithm that is with artificial intelligence with clinical data. So what we are performing, we retrain the algorithm. Our first algorithm was looking for the pregnancy. So if the patient is pregnant and the ERA was receptive, we correlate this part. And now we are correlating more with baby born, because at the end, we don't want a patient that gets pregnant or has an implantation, ongoing pregnancy rate, but a healthy baby at home. And this is what we are looking now. We are looking for an algorithm that says, okay, how many times you say it's receptive and patient have a baby at home? And this is what we are looking at right now. The algorithm is looking for the time that the patient is going to be a baby at home, even though we know that this is not the only thing that the patient has to be properly in order to get pregnant. I don't know if this is kind of was the question, how we do the analysis.
Yeah. But like the interpretations, what Dr. Deshmukh has asked for is that ERA can tell us whether the endometrium is receptive,
yes,
or it's non-receptive. If it is non-receptive, is it pre-receptive or post-receptive? Can we transfer it and post-receptive? Yes, we can transfer if the window is not displaced by more than 48 hours on either side of the receptivity scale. So that is what I think, Dr. Deshmukh, if you can share your mail ID with us, surely we will send you a detailed mail, because in short, it won't be possible to explain the whole interpretations, because there are various kind of interpretations in ERA.
Yes,
so we can send you a detailed mail.
Yeah, basically, we explain everything on the report. We say if patient is receptive or non-receptive. If it's non-receptive, we explain if it's pre or post-receptive, and we do recommend what time they have to perform the transfer, if we already recommend the transfer, or when they should perform the second biopsy, if we find that they should make a second biopsy, again, only in 10% of the cases. So everything is explained there, but sure, I don't have any problem to share my email, and then I can get the answer and so the question, and I can give the answer about the different kind of interpretations.
This was a wonderful session. I appreciate this. I would like to thank you again, Nasser, for being so kind and patient. And thank you very much, audience. It was wonderful to have you with us this evening. And we are having these thoughts of coming out with more such sessions on different services, of ours. So we will definitely send you a notification in advance pertaining to the same. So thank you very much once again for being here with us. God bless. Stay safe. Thanks, Nasser. And thank you very much, Angie.
Thank you very much to all.
Thank you.